Narcolepsy represents one of the most misunderstood neurological disorders affecting human sleep-wake regulation, a complex condition that extends far beyond the popular image of individuals suddenly falling asleep mid-conversation. At its core, narcolepsy involves the dysregulation of boundaries between sleep and wakefulness, allowing elements of sleep to intrude into waking and aspects of wakefulness to disrupt sleep. This neurological disorder manifests through a constellation of symptoms, including excessive daytime sleepiness, disrupted nighttime sleep, sudden muscle weakness triggered by emotions, cataplexy, sleep-related hallucinations, and episodes of sleep paralysis. Rather than simply causing sleepiness, narcolepsy fundamentally disrupts the brain's ability to regulate the timing and transitions between different states of consciousness, creating challenges that affect virtually every aspect of daily functioning. The science behind narcolepsy has advanced significantly in recent decades, revealing two distinct types with different underlying mechanisms. Type 1 narcolepsy, previously called narcolepsy with cataplexy, involves the loss of specialized neurons in the hypothalamus that produce hypocretin, also called orexin, a neuropeptide critical for maintaining stable wakefulness and regulating REM sleep. This loss appears to result from an autoimmune process where the body's immune system mistakenly attacks and destroys these essential neurons, often triggered by environmental factors in genetically susceptible individuals. Type 2 narcolepsy presents with similar excessive daytime sleepiness, but without cataplexy and, generally, without hypocretin deficiency, suggesting different underlying mechanisms that research is still working to fully understand. This neurobiological understanding has transformed narcolepsy from a mysterious condition often misattributed to psychological factors into a recognized neurological disorder with specific biomarkers and targeted treatment approaches. Excessive daytime sleepiness represents the cardinal symptom of narcolepsy, though its nature differs qualitatively from normal fatigue or sleep deprivation. Individuals with narcolepsy experience persistent sleepiness regardless of how much they sleep, often describing an ever-present sleep pressure that never fully resolves. Unlike healthy individuals who can generally fight off sleepiness through activity or stimulation, those with narcolepsy experience overwhelming, often irresistible sleep urges that can occur even during engaging activities. Many describe these as sleep attacks, where consciousness rapidly fades despite their best efforts to remain awake. This relentless sleepiness affects every aspect of daily functioning, compromising work performance, limiting social activities, increasing accident risk, and often necessitating strategic napping just to make it through the day. The persistent nature of this symptom frequently leads to misdiagnosis as depression, chronic fatigue, or insufficient sleep before the true cause is identified. Cataplexy, sudden episodes of muscle weakness triggered by strong emotions, stands as the most distinctive symptom of type 1 narcolepsy, occurring in approximately 70% of these patients. These episodes essentially represent fragments of REM sleep muscle paralysis intruding into wakefulness while consciousness remains preserved. Laughter represents the most common trigger, though other positive emotions like surprise, excitement, or pride can also precipitate attacks, as can negative emotions like anger or stress in some individuals. Episodes range from barely perceptible weakness, slight drooping of the face, slurred speech, buckling knees, to complete muscle paralysis causing falls. The preservation of consciousness throughout these episodes creates particularly distressing experiences, as individuals remain fully aware yet unable to respond or move. Over time, many people with narcolepsy develop emotional restraint, unconsciously suppressing emotional reactions to avoid triggering cataplexy in public or potentially dangerous situations. Sleep-related hallucinations and sleep paralysis often accompany narcolepsy, representing additional intrusions of REM sleep phenomena into wakefulness or the transition between sleep and wake. Hypnagogic hallucinations occur while falling asleep, while hypnopompic hallucinations happen upon awakening, both involving vivid, often frightening perceptual experiences that feel entirely real. These typically involve visual elements, though auditory, tactile, or multisensory hallucinations also occur, creating experiences that can be terrifying until understood as symptoms rather than supernatural phenomena or signs of psychiatric illness. Sleep paralysis creates equally disturbing experiences where individuals awaken mentally but cannot move or speak, often accompanied by a sense of pressure on the chest and intense anxiety. While these phenomena occasionally occur in the general population, their frequency and intensity in narcolepsy reflect the underlying dysregulation of sleep-wake boundaries characteristic of the disorder. Disrupted nighttime sleep represents a paradoxical but equally debilitating aspect of narcolepsy often overlooked in popular understanding. Despite profound daytime sleepiness, most individuals with narcolepsy experience fragmented nighttime sleep with frequent awakenings, vivid dreams, and sometimes behaviors like sleep-talking or excessive movement during sleep. Many describe their sleep as unrefreshing despite adequate duration, contributing to the persistent daytime sleepiness. This sleep disruption stems from the same neurobiological abnormalities causing daytime symptoms, particularly the dysregulation of sleep architecture, with abnormally rapid transitions into REM sleep and frequent shifts between sleep stages that would normally remain more distinctly separated. The combination of irresistible daytime sleepiness and disrupted nighttime sleep creates a particularly challenging situation where neither wakefulness nor sleep functions optimally. Diagnosis requires comprehensive sleep evaluation, often following years of symptoms misattributed to other causes. The diagnostic process typically begins with standardized questionnaires assessing sleepiness and other narcolepsy symptoms, followed by objective testing. Polysomnography, overnight sleep study, helps rule out other sleep disorders like obstructive sleep apnea while documenting sleep architecture abnormalities common in narcolepsy. The multiple sleep latency test, MSLT, provides crucial diagnostic information by measuring how quickly someone falls asleep during scheduled nap opportunities throughout the day following the overnight study. People with narcolepsy typically demonstrate pathologically short sleep latency, under 8 minutes, and abnormally early REM periods during these naps. Cerebrospinal fluid analysis measuring hypocretin levels provides definitive diagnosis for type 1 narcolepsy, though this invasive test is not always required when symptoms and other testing strongly suggest the diagnosis. Genetic testing for the HLA-DQB1*06:02 gene, present in most but not all type 1 narcolepsy patients, sometimes provides supportive evidence. Treatment approaches for narcolepsy focus on symptom management through both pharmacological and behavioral strategies tailored to each individual's symptom profile and circumstances. Medication options have expanded significantly, with different agents targeting specific symptoms. Stimulants like modafinil, armodafinil, and methylphenidate help combat excessive daytime sleepiness by promoting wakefulness through various mechanisms. Sodium oxybate, gamma-hydroxybutyrate, uniquely addresses multiple symptoms by consolidating nighttime sleep and reducing cataplexy. Certain antidepressants effectively suppress cataplexy through their action on neurotransmitter systems regulating REM sleep. Newer medications targeting the histamine system or hypocretin/orexin receptors represent promising advances in narcolepsy treatment. Beyond medications, strategic scheduled napping, consistent sleep-wake schedules, and good sleep hygiene practices provide foundational management strategies. Safety considerations remain paramount, particularly regarding driving and operating dangerous machinery during periods of peak sleepiness. The psychosocial impact of narcolepsy extends far beyond its physiological symptoms, affecting education, employment, relationships, and emotional well-being. Studies consistently document higher rates of educational difficulties, unemployment, and underemployment among people with narcolepsy compared to the general population. The unpredictable nature of symptoms like sleep attacks and cataplexy creates social anxiety and isolation as individuals worry about embarrassment or misinterpretation of their symptoms.